The topic is acute pericarditis. Inflammation of pericardium is there. Most commonly it's post-viral and most cases are idiopathic. There's several causes that lead to this condition. Patient presents with chest pain and that's kind of worsens on inspiration and coughing, and pain could be continuous for hours and patient may complain of pain over several days. The important thing about the pain is that it's kind of worsens when the patient is lying flat in supine position, and when the patient gets up, sits up, and leans forward, the pain is relieved. Location-wise, it's more like substernal and more towards the left side of the chest, and it kind of radiates to the back and the neck and the left shoulder, or the trapezius muscle towards this trapezius muscle ridge. Patient may present with dyspnea, cough, and fever, and the pain may be quite similar to that in myocardial ischemia. And as mentioned before, it can radiate to the neck and the arm. Several causes, as mentioned before, the viral infections being the most common, such as the echovirus and HIV and Coxsackie B, and bacterial infections could incorporate the Mycobacterium tuberculosis and the Haemophilus influenzae, and the Staphylococcus or pneumococcus. Uremia is an important cause as well, and radiation-induced raisins and the neoplasms such as the breast, the lung, and the ovarian neoplasms, and then the leukemias, the lymphomas, the melanomas, and the mesotheliomas, although rare, and it could be dialysis associated, and it could be related to situations wherein displacement of ICDs and pacemakers, and then traumatic conditions as in blunt trauma or in chylopericardium, and in penetrating traumas. Drugs can lead to this condition as hydralazine, procainamide, minoxidil, happen in autoimmune disorders as in rheumatoid arthritis and SLE, or it could be post-MI, immune-mediated pericarditis as in Dressler syndrome. And then there's a friction rub. And when the patient leans forward and at the end of expiration and best heard on the left sternal border, there's a rub that can be appreciated. Typically, the nature of the rub is sound-wise, it's high-pitched and it's squeaky and scratchy, and basically it consists of three components, and as atrial systole, ventricular systole, ventricular diastole. But in reality, the triphasic rub is seen and reported in about half the patients, and the monophasic and biphasic rub is seen in the rest. The biphasic is seen in around 1/3, and the monophasic is seen in the remainder. So essentially, the triphasic is in about half the patients, the biphasic is in around third of the patients, and monophasic is in the remainder of the patients. A word about the Dressler syndrome. Um, After myocardial infarction, this kind of occurs weeks to months after MI, and there is pericardial effusion that can be associated with this condition, and this pulmonary infiltrates and pleural effusion and malaise and fever and serositis, and it's basically due to an immunological reaction. And even in situations after cardiac surgery, it can lead to uh, pericarditis as a post pericardiotomy syndrome, and there is a possible hypersensitivity kind of reaction of the injured myocardial tissue, and this is possibly the reason for the post pericardiotomy syndrome. And lab-wise, one could go ahead and do the C-reactive proteins and the ASRs as a marker of inflammation, and the inflammatory markers are often increased, as the white blood cell count is also often seen increased, and one could go ahead and do the serum creatinines, the BUNs, and test for HIV, anti-nuclear antibodies, and several other tests can be done depending on the history and the physical examination. And in situations where there has been a MI kind of a condition, appropriate tests can be done accordingly. So a pericardial friction rub is often heard, and often there is elevation of JVP, and pulsus paradoxus is also present. That's basically a decrease in systolic blood pressure greater than 10 mmHg on inspiration. Ecg changes wise, often there are changes, those are noticed, that evolve over a period of time, stage by stage. And initially one could see a diffuse ST segment elevation with PR segment depression, almost all the leads except the AVR. And then there could be then normalization of the ST and the PR segments. And then one would see widespread T wave inversions and then normalization of the T waves. But there would not be any reciprocal ST segment depression as one would see in the case of acute MI. And on echocardiography, one would see pericardial thickening or effusion, but if the effusion is absent, it does not rule out pericarditis. Echo also helps to rule out the tamponade and constrictive pericarditis. Then a tuberculin skin test also helps to get an idea of the mycobacterial infection. And then pericardiocentesis uh, is also at times performed, especially when the effusions are small or moderate. Chest x-ray wise, one could appreciate enlargement of the cardiac silhouette, if there is fluid accumulation, and calcifications could be noticed around the heart in advanced situations, and if there is constricted pericarditis, and primarily to figure out if there are any issues with the mediastinum or the lung fields that could lead to pericarditis. A chest radiography is handy. Then treatment-wise, rest, and then anti-inflammatory therapies such as NSAIDs, aspirin, and colchicine can be an alternative for patients cannot tolerate NSAIDs and steroids, but colchicine can also be used in combination with NSAIDs. And then, of course, steroids for suspected connective tissue diseases, and corticosteroids or immunosuppressants for SLE. And then for uremia, um, dialysis for uremia, and then avoid steroids, avoid corticosteroids within a few days after MI, and the good possibility of predisposition to ventricular wall rupture, and pericardiocentesis can be performed if there is evidence of tamponade with continuous drainage as needed. Aspirin can be utilized for post-MI pericarditis, and aspirin or NSAIDs for viral pericarditis. And then for purulent pericarditis, one could go for pericardiocentesis and IV antibiotics, but it's important to basically monitor for cardiac tamponade or constricted pericarditis in condition of pericarditis. And also one should avoid anticoagulants, especially in acute phase. So there's always a risk of intrapericardial hemorrhage and tamponade. Hospitalization can be required in special situations where folks have like high-grade fever, and then basically in immunosuppressed situations, in traumatic situations, and situations where there is large pericardial effusion, and as seen on echo, and then situations of cardiac tamponade or MI. So there are several situations wherein hospitalization is required as well. But routine hospitalization is not necessary.